So my name is Ronnie Shure, and I'm the president of Healthcare for All Washington. We welcome you to tonight's meeting. Uh, we have a special guest, AnnaLisa Gellermann from the Healthcare Authority, who is the board manager with our Healthcare Cost Transparency Board. We will be posting a link on our chat and chat board, I guess is the right word. We'll be posting the donate button. So anytime during this meeting, you can go in and make a donation at that website. Um, you can also volunteer to join us. Go to that website and negotiate to the or move to the get involved, the button that says get involved, and please join us in one of those many different ways. We have set a goal tonight to raise $237.27 during this program. That's a probably jovial approach to helping to pay for some of the basics of our actions as well as putting on programs like this. So if you are able, please negotiate to that site, make a donation, volunteer. We love to hear your ideas on how we can move forward towards universal health care for everyone. Please add your questions and comments in the chat. We will have AnnaLisa's presentation first, and then we'll have a short intermission or a short message from Peter Lucas, who is our fundraising chair, another member of the board of Healthcare for All Washington. And he then will get directly into those questions, question and answer portion. We've have enabled closed captions. So if you want to view that, you can go to the bottom of your Zoom screen, kind of in the middle. There's an icon that says CC for closed captioning, and it says live transcription. So just hit that up arrow and enable that so you can follow those words along or follow along with the words. And as I said, please add your questions in chat as we're going along. And then Cello Echeverria, another member of our Healthcare for All Washington, will be asking those questions after we complete the program. So let's start, or the AnnaLisa's presentation. So let's start with the land acknowledgement. I am participating in this Zoom meeting today from the lands of the Coast Salish peoples. Please take a minute to acknowledge the peoples in the lands where you are joining us today. We acknowledge all of the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Our efforts to achieve healthcare for all include universal healthcare coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. So tonight's program features AnnaLisa Gellermann. And I'm going to ask her to unmute, and I'm going to bring her up on the screen with me.
Hello, everyone.
So AnnaLisa has been with Washington government for 20 years. serving as a public lawyer, regulator, and a manager in the field of health insurance and health policy. She said she's enjoyed that career, and I think she has displayed that in her current managerial board, a role with the Healthcare Cost Transparency Board. She worked with Attorney General Christine Gregoire. We all remember her and her progress in our state. Attorney General Rob McKenna, so she goes way back. She also worked at Labor and Industries, and and the Office of the Insurance Commissioner, where she became the Deputy Director for Legal Affairs, and then became the first woman in the role as Chief Deputy of Insurance of the Office of the Insurance Commissioner. And then in 2021, she moved over to the Healthcare Authority and became the manager of this board that we're going to talk about tonight. She has been active in WISHIP and various organizations around the state, and currently is on a board member for Kids Chance Washington, whose mission is to provide educational scholarships to children and to spouses of Washington workers who have been permanently or fatally injured in a workplace accident. She lives in Olympia with her partner and her terrier, Rosie. And so I've muted everyone but AnnaLisa, so let's get started. If you want to go ahead and share your screen.
I will, thank you. There is nothing like sitting in a giant picture next to someone while they read about you. I hope that you can all experience this marvelous feeling. I'm very glad to talk less about me and more about what I came here to share with you, which is the Healthcare Cost Transparency Board. But I am very happy to be invited. I thank Ronnie and the board for giving me the opportunity to come here and talk to you today. I hope I am now sharing my screen. I hope that what you see is a big screen that says Washington Healthcare's Cost Transparency Board with my name under it. Can you see that, Ronnie?
Looks very good.
Good. And can you hear me? The audio sounds good to folks.
Yes.
Okay, great. And thank you for that very kind introduction as well, Ronnie. So I'm familiar with this organization, and I know some of the excellent work that you've done. In fact, one of the things that you've supported recently was the creation of this Healthcare Cost Transparency Board. So, which I think is a very good idea, as you know, because I decided to come and help it spring to life. Progress is slower than we would like, but I think having a citizens group such as yourself working hard to advance the cause of equity and access is really important. You may not know that I am also, in my small unit is the Universal Care Commission. So my unit at HCA is called the Board and Commission Unit. So we support this board and also the Universal Care Commission. So both close to my heart. So I am here today, though, to talk to you about the Healthcare Cost Transparency Board. So I'm going to move on to the next slide. So today I'm going to talk about the basics of the Healthcare Cost Transparency Board. So I think you guys are pretty savvy, and if this is too basic for you, I apologize. We'll just do a level set and make sure everyone knows it's a complicated concept, especially I think for many consumers who are kind of looking at healthcare from a particular viewpoint of consumer access and consumer costs. So I'll step you through the basics of the Healthcare Cost Transparency Board. I want to talk to you a little bit about our view of the problem that we're working on, which of course is a problem of cost, and what the board is doing now. And then there'll be time for questions. And I hear that Ms. Echeverria will be helping pass the questions through chat. So thank you for that. So what is a cost growth benchmark? So a healthcare cost growth benchmark is an annual rate of growth benchmark for healthcare cost for a given state. So it's, or some people call it a target. So, and why do you pursue a cost growth benchmark? Because you're trying to curb healthcare spending growth. So let's pause on that for just a minute, because the straight talk about the cost board is that it does some things and not others. So one of the things that it's going to do really well is look at the market broadly and at a high level. And it's going to say, how quickly are these costs growing? And compare between markets and entities and come up with ideas about that. Unfortunately, one of the things that and it's going to focus on curbing that growth. Some of the questions I get is, what are you going to do about cost today? And I'm like, well, the cost growth board really looks into the future. It looks at curbing runaway cost growth. And then another thing that comes up is, what is it going to do for consumers right now? How does this translate into what I'm paying for medical costs? And the answer is, unfortunately, this is not the most direct intervention for that. Again, this is kind of looking at future healthcare costs. So in the future, it's going to mean that consumers hopefully will spend less than they otherwise would have. That's not a very inspiring bumper sticker, but it is kind of what this work is about. As you know, the cost problem takes so many different kinds of interventions. I liken this problem to like water rising in a room. So if you're in that room with water rising everywhere, you've got one group that is working on flotation devices. How do we keep people floating? How do we get them the access that they need? You've got another group who's hopefully working on keeping the water from rising so quickly. That's like the cost board. We want the water to, we understand it's going to go up. We want it to go up very slowly. Then you got another group that's more like universal care that is saying, let's get out of this room altogether. Why are we in here with this rising cost the way it is? So there are many interventions in the problem, and the cost growth benchmark is one of them. So what is the purpose of the cost growth benchmark? I talked a little bit about that, but it is to increase affordability through lowering the growth of healthcare costs to a sustainable rate. So it acknowledges, like with everything else, cost goes up over time, which is kind of how it goes, but you'll see later that cost is growing, as I think we all know, at an unsustainable rate. We also have new work on the cost benchmark board, which is primary care spending. I'm not going to talk too much about that tonight because it's a new beginning. It just started with this legislative session. But you may be aware that the legislature has passed a target of 12% for total healthcare spending. So 12% of what we spend, they say, needs to be spent on primary care. And that is related to cost, because I think we all believe that and have seen in some data demonstrations that investing in primary care is not only great for people, it also, and public health, it also lowers eventual costs. Just makes sense. People are getting care sooner, they're getting more preventative care, they're generally healthier. So it does have an impact on cost. So we will be working on that. I'll touch a little bit more on that later. And the board not only this is their mission statement, increase affordability for the people of Washington. So this board is focused on how their work will help people. Even though I just told you it doesn't help them as directly as some other interventions, that's what my board is focused on. And they've identified these considerations that are really important to them as they look at cost and they look at recommendations about lowering the cost curve. We call those cost mitigation activities. They're very concerned that we keep an eye on affordability and access for people. We don't want to put in recommendations and mitigation efforts that make it harder. The board's very concerned about quality of care. Don't want to measure one thing, cost, and sacrifice another, quality or access. And they're very interested in spending on health-related social needs. This comes with a lot of different names, but it's focused on vulnerable populations, on appropriate support for people, including the uninsured and other people who don't have regular access. So that's kind of the board's heart-centered mission statement. So the board itself is made up of 14 members, and it's a governor-appointed board. It's administered by Healthcare Authority, but it sits a little separately. It's got 14 members that were appointed by the governor, and this legislation is also bipartisan, so it got support from both sides. And it is representative of purchasers. Remember, this is a high-level economic intervention, and what it's looking at is what are people spending. So what this board wants to do is have people on it who are spending healthcare dollars and have them really look at what is impacting that spending. So it's got representation from a lot of different purchasers, large and small businesses, some of them very small, local and state governments, those who purchase and regulate healthcare, the University of Washington. We do have a consumer representative appointed by the governor on the board. That's Margaret Stanley. And the board is statutorily constructed. It's got a recipe that the legislature came up with about who needs to be represented on the board. Then we have 3 advisory committees, and this is where we have, this is also the first 2, healthcare providers and carriers and data issues, are both in the statute as well. So the healthcare providers and carriers has a list of trying to be as broad as possible with stakeholder groups. So we've got ARNP and WISHA and WISMA and many of the large insurance providers in the state. We also have a consumer representative there, Dorothy Teeter, and we have individual providers as well, including, representing family physicians and kind of some larger systems. Then the advisory committee on data issues is really acknowledging that this is a lot about data and data analysis. So it has actuaries and data experts from all sorts of different backgrounds, academic and insurance and medical. And then we are just starting to make a primary care committee. So let's talk, well, I wanted you to see this just in case anyone was interested. You might recognize some of these names. And that is the board members. And you'll have this slide if you'd like to look at it more later. I'm not going to land on it for long. So let's talk about transparency, because we are the Healthcare Cost Transparency Board. So when we talk about transparency, I think it's really important to start the conversation with what kind of transparency you're talking about. And so we think about 3 kinds, and this is one of the reasons it's so hard to figure out what healthcare costs and what's really going on, is that we have all these different ways of looking at it. So one of the things you want to look at is price transparency. And when we talk about price, we're talking about how much a provider is charging. And usually they're charging an insurance company. Sometimes they're charging a consumer, an individual. Then we talk about reimbursement. So that's the payment that's going to be made, usually by a third party, usually maybe an insurance company, maybe an employer, for services. And you can see all these different kinds of reimbursements, and that also complicates trying to figure out what is being paid, because you have fee for service, meaning I go to the doctor and I get, an x-ray, and I'm charged for an x-ray and a visit. So fee for service. Then you've got per diem is another kind, which is days in hospital. You've got different diagnosis related groups. So you might go in to be treated for a certain kind of diagnosis, and a lot of things might happen to you and it's all charged under one diagnosis related group. That could be maybe diabetic treatment or maybe a behavioral health episode. And then you've got what we call capitation, which means you might get a certain fee for people under your care. That's a typical thing in contracts that are trying to emphasize quality of care over price. They're like, don't charge me for each service, just we're going to pay you for each person in your care. So that's price and reimbursement. What we're really talking about is cost. So cost also means a few different things. It means to providers what expenses they incur. So if a provider says cost, they're talking about supply cost and labor cost and facility cost and all of the things that go into what it costs them to provide service. Of course, to payers, that's insurance companies and employers, it's the amount they pay to the provider for the service rendered. That's what they mean when they say cost. Now, you and I, when we say cost, we mean what we're paying out of pocket. And for those of us who are insured, good Lord, try to figure out the relationship between these 3 things on your bill that you get from the insurance company. You'll get a headache pretty quick. For the uninsured, unfortunately, it's often a startling bill, and they really don't, again, because there's none of the relationships that create that to be a different thing. So here are a couple complicating factors. The relationship between cost and price is really unclear. We don't have that one-to-one. Hospitals will have a charge master that is a list of hospital prices, but that's an entry point, right? That charge master kind of says, here's what we think we'd charge, and what they actually charge can be really different. Another example of that is a MAC list. That's a maximum allowable cost. It's for pharmacy purchasing. It purports to be a list of prices, but hard to know how that's being charged, because it is changed by the relationship between the purchaser and the provider through contracts and negotiation and rebates. And so I'm trying to just paint a picture for you of the system we've built that makes it almost impossible to understand cost and price in a way that consumers can readily look at. We have a couple of cost resources for payers. For consumers like us. So in Washington, I don't know if any of you have seen Washington Healthcare Compare. So that's a little tool that you can go to online, and you can type in what you're looking for in your zip code. You can do it right now if you're sitting at your computer. And if you go in there, for example, you could type in, I need a blood test. And you could type in your zip code, and it will tell you the price, the average price in your area. Now that's all based on claims information in our Washington All-Payer Claims Database. I'll point out that it is for insured people, so it might not really help you if you're looking for the pure cost of uninsured. But that is one step in the direction of transparency, trying to make it a little clearer to consumers what most people are paying for a particular kind of service. So the cost to a patient. And as I said, this is all highly impacted by contracting variables, including the volume, network availability, other contractual arrangements. And of course, those contractual arrangements are not available to the public. They're between the payer and the provider mostly. So hard to see. I have buried my arrow button that lets me go on to the next screen. I'm trying to click it. We'll see what happens. Oops, wrong way. Come on, little screen. Let's see if I can do it over here. All right. So let's talk a little bit about the economics of cost growth, and I'm conscious of time. We'll move along. So this is what the cost board started looking at, is when I said healthcare cost is going up too quickly. You can see some of these other percentages that we keep track of as basic economic indicators, per capita, GDP, wage growth. And we can look at all of these and see that healthcare service spending on the bottom there is outstripping them all. That's a first indication that there's a problem. Something is out of balance, especially for consumers. When you see healthcare going up so much more quickly than wage, that's a big problem. Let's look at the economics of cost growth overall. So we as a country spend too much. In 2017, we spent 17.9% of our gross domestic product on healthcare services. You can compare that to Switzerland, which spent second highest, only 12%. So we spend a great deal. And actually, we just saw headlines a little while ago. I need to update this slide that it's predicted to go up to almost 20% in the next couple of years. So a fifth of what we spend as a government is spent on healthcare. And then nationally, total healthcare spending was 1.4 trillion in 2019. The reason these are kind of old is healthcare data it takes a little while to mature. So by the time we get it all together and we understand what we've spent, then, and then we put the report together, we're always a couple years behind. So these get updated. This will get updated in another few months, and we'll see what we spent in 2020, and it'll be higher. And government spending represents 45% of that total spend. So government spending in Washington would largely be represented by Medicare, Medicaid, what the state spends on its state employees. So PEB/CEB, probably we would include Department of Corrections medical spending, L&I's labor and industries medical spending, 45% of that spend. And the reason, of course, that's so significant is you think, gosh, what else could we be spending that on? When you look at the state of education and you look at the state of, whatever your particular concern is, children, potholes, social justice, we're spending too much on healthcare, and we don't have enough to invest in these other as much as we would like to invest. So we'll look at the problem of the growing cost of insurance. And I know I'm preaching to the choir, so I'll go through these quickly, but these are charts that we have developed at the cost board to really make that case of growing cost to people who haven't been following it as closely. So you can see here, this is about cost of insurance. So to some extent, these are the haves, right? People who have insurance, not the have-nots. But you can see, if you look at that bottom line is per capita personal income, and then you look at the growth curve of what people have been paying for family premiums, and that's insurance, or as employees, your contribution to your premiums that you get through your employer. So a wider and wider gap. And that is going to impact what you get from your employer. That means less wages for you because they're spending, or, potentially because they're spending more on healthcare. It means different choices in a family as they pay more for healthcare as a larger percentage of their income. That's what that chart is demonstrating. And you can see that it's kind of going up even a little quicker after 2013. And the problem of growing consumer cost for care is the average share of household budgets devoted to healthcare increased from 5.2% to 8.2% over 30 years. You can see middle class family spending increased hugely. And the bottom is really the best statistic about access. 7% of insured and 28% of uninsured said they delayed or did not receive medical care due to cost. And these are Kaiser Health statistics. These are national statistics. And I'm pretty sure that you in this room are familiar with them. So the cost benchmark is a brainchild looking at this, the complexity of cost and price, looking at this kind of growth problem. And I will tell you anecdotally, another thing that is at play here is the fact that we don't seem to have a great solution. We don't know who's supposed to control this, right? We all believed when the Affordable Care Act came in, that was kind of a government position that said, look, insurers will be empowered to get good deals from providers. Let's keep that negotiating going. Let's fund it additionally to make sure that consumers get a better shake. But we think the market will mind itself, and those big players will be able to keep prices down because that's competition, right? That's a capitalistic principle. What we have noticed is that it's not really working. And that in a latest in a survey that I read about a year ago in the Pacific from a national lobbying group of large employers, is 90% of their employers said we need government regulation, we need something different, because we as large employers don't feel we have the leverage to keep costs down. So in that very difficult condition, who has leverage to keep costs down? What are we going to do? Comes Massachusetts. So they did the first cost growth benchmark. They had some of the highest healthcare costs in the country. And in 2012, they put in a benchmark saying we're going to keep cost growth below a certain percentage level. And lo and behold, it dropped down below that level. And of course, people always ask, why does it happen when you just put out a number? And there's other activities that go along with putting out a number, but I think expectation and transparency can be pretty powerful change agents. So there is demonstrated experience in Massachusetts that a cost benchmark, along with careful data analysis and public discussion of that data, can have a real impact on bending the cost curve, which is why 7 other states have adopted a cost benchmark, including most recently California. So we are in a group together with California, Oregon, and Washington, so the whole left coast, Connecticut, Rhode Island, Massachusetts, New Jersey, and Nevada are all doing cost benchmark. And it's very new. Massachusetts started a long time ago. The rest of us are about 3 years in. So the legislative charge for our own healthcare cost transparency board is this: hey, make a benchmark, get a percentage, collect data from payers. So that is one of the things that drew me to this work. Is typically when we talk about cost, we talk about it by market. We say we have a lot of information about what's happening in Medicaid, how much it costs, how it's being spent. We have a lot of information about what's happening in Medicare. Payers, like a big insurance company, will have a lot of information about what it is spending. But we don't really have a great way to look across all markets and look at the problem altogether. And this causes a lot of mischief. It's kind of like in a family budget. If you looked at groceries completely separately from utilities and never talked about the two of them and the impact they might have on your budget. I think it causes a lot of imbalance and a lot of confusion. So we're going to collect aggregate spending data across the whole state from the 11 largest insurance company payers, and state agencies. That's going to be about 90% of payers, 90% of the money spent in healthcare, including HCA, who's a large purchaser. We're going to determine a new thing called total healthcare expenditure in Washington state. That means the best we can get, how much money is spent in Washington specifically every year on healthcare. And I know a lot of people will be interested in that. Universal Care is interested in that. The government is interested in that. So that's going to be interesting. And for the first time, we won't have to guess what we're spending based on a national study. This will be Washington specific. It also includes what consumers are spending. Unfortunately, we can only capture what they spend in the insurance context, because that's where the data is. When you're uninsured and you're paying out of pocket, nobody's tracking that in terms of reports on data. We might get there one day, but for now, it's going to be what you pay in copay and co-insurance and out of pocket, but that's represented in that money too. Then we're going to analyze Washington specific cost drivers. So out of that data, we're going to be able to look at what segment, what markets. By that, I mean, who's growing the fastest? Medicaid, Medicare, commercial insurance. We're going to be able to look at what sector is growing the fastest: inpatient, outpatient, pharmacy. Then we're going to dive even deeper into some Washington specific cost drivers, looking at conditions and geography, and to the extent we can, social determinants. That's a developing field of data. And then we're going to take all that information and provide annual reports. Transparency, it's in our name. We're going to make reports. Our data will be available. Our reports will be available to everyone. We will make recommendations to the legislature based on what we find. And new, I mentioned that earlier, we are going to start developing a primary care target of 12% of that total healthcare expenditure figure up there. So that's what the legislature said needs to be hit. And we're gonna first, we need to define primary care, then figure out how to measure it. There's a lot of challenges there, and then report on it every year. So this is our cost benchmark. And you'll see, I think the interesting thing about it is the board based it on historic median wage. Lots of conversations. You could base it on lots of different things. But what they said is, look, it really matters to us what consumers can afford. So their formula is take 70% of what the historic median wage is and 30% gross state product, which means, it's basically our state economy and takes into account inflation and other factors. And that, if you do the math, which I didn't do, so don't ask me about that, but if you do the math, you come up with 3.2%. So that is our growth target for this year. We want expenses not to go up more than 3.2% this year. I don't know yet if I'm just now collecting data, so I'll be able to come back next year and tell you how I think we did. Currently, our board and advisory activities are this. So we're doing the 2022 benchmark data call. The doors open August 15th, but it's like anything else. There's a tremendous amount of preparation that has to happen before those doors open. And we've been doing that both technical specifications and submission manuals and working with issuers. So all of that data is going to start to flood into the servers on Healthcare Authority, and we're going to sort it and organize it and do all those things. We are designing our cost driver analysis tool. So we are working with some experts in the all-payer claims database, and then a team of people with a bunch of different points of view, both clinical and data. And we've got some people on there who are interested in long-term care and other state benefit, other health benefits in public health. And we're going to try to come up with the best tool we can. That will be a tool that we can hopefully interact with and ask questions about as we dive more deeply into what is driving cost. Then the board has selected some priorities to look at this year. You may have been following along and seen they're looking at hospital cost. We have an exciting presentation coming up. Darn it, I did it again. I put August 20th. It's August 17th. I don't know why I have the 20th in my mind. It's next Wednesday. So come. Of course, if you miss it, it's recorded and on our website. And that is some independent consultants who are looking at Medicare cost reports, which is self-reported financial data from hospitals. And they're just kind of plotting out, based on what they tell us, are all hospitals the same? Are all hospitals, or are they different? And I think most of us would say we know they're different when it comes to cost and to price. So we're starting our educational journey and looking at hospitals. We are going to look at pharmacy cost. Again, a real brain bender as far as how the pharmacy supply chain works. And we're looking deeply at value-based payment. For a long time, we've understood that value-based payment, we know that its main aim is to improve quality, but there's always been a question about, will it improve cost? If you're making more upfront investment, if you're paying people for total health. So the board would like to help kind of investigate that area of it. And we're beginning our primary care work. We're forming a committee of subject matter experts in primary care, and they'll be advising the board on recommendations again about defining primary care, measuring primary care, and then reporting to the legislature. And this is my last slide. So how could all this data be used? So the exciting thing about it is that, again, for the first time, we'll be looking across the whole market. So we can do a lot of comparisons between them about how they're doing. So if you can highlight variance between states, between Washington and California, between markets, between different insurers, and all of this is going to be public again. You will be able to look. Not right away, because we have to get good at this. So in 2024, you'll be looking and seeing which insurers are doing a better job of holding down the cost curve. And we're looking at very large provider systems. It's never going to be, how's Dr. Jones doing on the cost benchmark? He's not big enough to have the kind of size data that we need. But we will be able to look at large provider systems. And one of the things we can do is learn from people who are doing a better job. So that becomes transparent too. We go see them. Why are you doing a better job? And conversely, why are you not doing well? And that becomes part of a public conversation. That something like that kind of performance has never been possible. And it will be in a pretty short time, to hold people transparently accountable for how they're doing on controlling costs. So we're going to create a common expectation of controlling costs. Doesn't sound very big, but as I said, in Massachusetts, it turned out to have some real legs. And hopefully we will see some of those impacts here in Washington. And then we're going to identify areas of focus for curbing costs. I already talked about high and low cost providers. We can talk about segments. I think we all guess that pharmacy is growing fast, or we've seen national data that pharmacy costs are growing faster. We'll see Washington data and we'll understand if it is truly growing faster and by how much. And then we can dive more deeply and see even more at a granular level what pieces are growing faster and how we can make recommendations to curb that. We'll look at best practices from high performers and we'll do deeper dives. So that is it. And I said questions, and I think I did okay with my time. Not perfect, Ronnie, but pretty good.
Pretty perfect.
And I'm ready.
I would say yes.
I'm ready for questions. And thank you so much.
And so put your questions into the chat. Thanks, AnnaLisa, for bringing up these issues about cost. And of course, it brings up all these other issues. If we can identify some of those factors, then hopefully we can identify ways to improve outcomes, because we're paying all this money.
Right.
You compared it with other countries or the rest of the world, and we're not doing better in outcome. So working on this data, it's kind of like the devil is in the details. If we can pull this data together and start identifying this underlying costs, it's exciting to see this happening.
Well, thank you. And I'm ready for a conversation that we can stop saying, well, I think it's this way, or I'm ready to just say, yeah, it's true. We have the data. It is growing faster. This is a problem. Let's fix it. I want to move beyond the discussion of, is cost a problem? Is this a problem? I believe the data that is transparent and well stakeholder can be very persuasive and move us into a solution phase, which is really what data is all about and transparency is all about.
So thanks for that. I see questions starting to show up. I see some
Great.
hands raised, but instead of raising your hands, if you could go ahead and put your question into the chat, that will give us a chance to prioritize the questions because we're not going to have time for every single question. So please go ahead and put your messages into the chat. You can also see our donation link in there. When you're entering questions, look for that link. Remember the 230 whatever and 27 cents. If you are able to give, please do that. And so while we're putting those questions together, let's ask Peter to give us a few words about why we need that money and what we're planning to do with that, and appreciate people that have been giving already. So, Peter, do you want to take a few minutes?
Sure. Well, this is the usual commercial break, and I know you're all dying to get back to the questions and answers, but I'm going to be a little long-winded and make a pitch for our organization. Many of you know that we've chalked up many successes. Our organization, Healthcare for All Washington, has chalked up many successes the past few legislative sessions. For example, we were the driving force behind the Universal Healthcare Work Group, and had seven of our members in that group. And their work led to the creation of the UHC, Universal Healthcare Commission, which is currently meeting. And this commission has many members that we advocated for as well. And it's tasked with creating a system to provide health care to all Washington residents. And they could craft a single payer system based on our bill, the Washington Health Security Trust. And as AnnaLisa just mentioned, we assisted in the passage of the bill to create the Healthcare Cost Transparency Board, as well as many other significant bills to improve healthcare in Washington, actually 22 in 2022. In order to maintain our momentum, it's vitally important that we grow our membership, educate the public, and mobilize our supporters to spread the word to their family, friends, and most importantly, their legislators. We can achieve these goals through social media, monthly webinars, meetings with civic groups, and by hosting other events. And now that COVID is retreating in Washington, we're getting out more from behind our laptops and smartphones and meeting with people in person. In addition, we're very pleased to have a new experienced and dynamic lobbyist, a communications specialist, but we also have other fixed costs we have to cover. And these activities and obligations all require funds, which is why we are asking you to donate tonight. And our goal tonight, as Ronnie said, somewhat tongue-in-cheek, is $237, and I believe it was 27 cents. So please go to the links in the chat or our website and click on the donate button. You can make a one-time donation, but we would especially appreciate it if you can make a monthly recurring donation. It's like a Netflix subscription, except you might get universal health care instead of cheesy movies. So please donate so we can spread the word and bring about universal single payer healthcare in Washington. And take it away, Ronnie and AnnaLisa.
So thank you, Peter, for pushing us along those lines. It's hard to make everything balance. So let me introduce Cello Echeverria, a very active member in Healthcare for All Washington, who has been behind the scenes reading your chat messages. She has prioritized, I hope, most of the first few questions to get started, as again, we probably won't be able to answer all of your questions, but why don't we get started? Cello, you have a first question in line? You'll have to unmute.
Oh, no. Now, can you hear me?
Yes.
I can.
Okay, sorry about that. So, our first question is, Medicare is repeatedly said to have insurance overhead of 3 to 5%. Washington Healthcare Authority controls 100% of Medicaid payments, which are all to private companies and for-profit, including foreign not-for-profit companies. Regarding transparency, what overhead does HCA permit to those companies for Medicaid?
I don't know the answer to that question. If I did, I would tell you, and I think that that's a reasonable question. But I don't know the answer of so the answer is kind of permitted overhead, which I also see as perhaps profit, the difference between what they pay and their administrative costs and what they get to keep. But I don't know the answer to that. I'm sorry.
Okay. So then we have another question. We have a couple of questions that are kind of echoing this, and I just kind of put them together. How do you envision patients and advocates increasing their involvement in the Health Cost Transparency Board to balance industry voices?
Well, I think that's great. And certainly your organization and others are talking to the board right now. So one of my jobs is to facilitate that conversation between consumer advocates and the board. In fact, I received a great letter that's going into board materials this month. And I think that we need to have conversations about how to do that. Certainly having people come and make public comment, getting letters from the board to the board. And the suggestion has come from consumer groups that we have additional representation. I think the board is eager for consumer voices. I think one of the pieces of that is our consumer advocate on the board, Margaret Stanley. I want to work with her to become more activated in making sure that we hear more directly from consumers. And we need to discuss things about what kind of presentations should come in front of the board and develop those with you. So we're working on that. It's in the forefront of our mind right now, and that's part of our job. And I'm open to suggestions.
I'm sorry, I didn't write down who asked each question, so I apologize to the viewers. But I thought this was a really important question to address. How is the board envisioning forcing reluctant payers to cooperate in submitting all relevant data?
Well, that is a really good question because, well, so far we haven't had any reluctance. So we are engaging with, as I said, 11 holding companies, which control numerous insurance companies in Washington, and they are all at the table taking it pretty seriously. Some of them are national companies who are experiencing this in other states as well, and they're actually talking about how to do that in several states. So if they are reluctant, we've already discussed, or if there is an issue, which we're going to wait to see if that develops, but certainly it would not be beyond thinking to go and investigate some kind of enforcement authority, either different authority through HCA or through the legislature. We take this seriously and we want that data. But so far, everyone's cooperating.
And then once again, having to do with enforcement, since we're on the topic of enforcement, are there any enforcement mechanisms behind the 12% benchmark for primary care?
Not right now. So that one is not, that one does not have an enforcement mechanism, and neither, frankly, does the cost benchmark target. Some other states, Oregon, for example, a couple of years after they started their benchmark work, put in an enforcement mechanism, which is about having performance improvement plans and a fine. So some other states are experimenting with that, and in Washington, we haven't started that work yet.
Yet meaning, is that something that the board will be thinking about as we move forward?
No, they've been asked about it, and I think it's something that they will consider, but we're so new right now. Kind of want to see how it works and what happens. I mean, I will say, looking at enforcement mechanisms in other states, it's not as easy. It's not easy to come up with an effective enforcement mechanism. For example, Oregon's their standard is if in the past 5 years you have exceeded the benchmark in 3 of those years without a good reason. I mean, it's much more complicated than that, but it's a difficult standard to figure out how to apply it and how to enforce it. So certainly the board's talked about it. And as I said, we work with other states. So we're all watching each other and learning from everyone's experience. So it's on the table, but it's not being actively pursued right now.
And then the final question is for me, which is kind of following up on my comment that I made at our last, at the last meeting, the first meeting I attended, but not my last. And I really appreciate that you're so open and that the Health Cost Transparency Board is open to participants and open to questions. I personally, and I'm just going to share personal, I'm speaking as Healthcare for All Washington. I'm very concerned that the Health Cost Transparency Board has taken on value-based payments as being a cure-all for controlling costs. When, as your gentleman, I believe his name is JR or JW, the one who
Oh,
presented.
JD Fisher. So he is the value-based payment manager at Healthcare Authority.
Yeah, exactly, because even he mentioned in the meeting that there was very little evidence showing that value-based purchasing or value-based payments are actually effective in limiting health costs, right? And in fact, other papers have shown that value-based payments and the ensuing extra costs of billing and insurance and administrative costs are a real driver of healthcare costs in the United States. So with that as a background, I'm curious, how do you see this move of Washington State and the timeline that he put up there of Washington State moving towards value-based payments? How do you see that as when we're talking about implementing an affordable universal health care?
That's a doozy of a question. So
I know,
first
and
of
I don't
all-
expect
oh,
an
no,
answer,
good.
but
Oh, no, I love big questions. And so let's see. First of all, the board's interest in value-based payment is really, I mean, it's one of a list, and I wouldn't say they're stuck to it for a really long time. We're looking at education. We're at the point right now where we need to understand very well the landscape of what's going on with cost and quality improvements in Washington so that we can take that data and make good recommendations. So they're looking at value-based payments, specifically kind of thinking about what you just said, that, there doesn't seem to be a lot of evidence that there's good evidence about quality, I think, but not such evidence about cost. Can we help with that? Can we find data? Can we be transparent about whether it has an impact on cost? Because part of what they do, they're not only about cost mitigation interventions, they're also about data transparency. So is there data that we need to develop? Are there barriers to that data that we can help put away? So that's kind of their interest in value-based payment. I think value-based payment has a lot to recommend it, especially if it's in a multidisciplinary practice setting where you're talking about, emphasizing quality of care and better outcomes for people. And there are some logical steps in it that kind of lead to universal care, as long as you're talking about synthesizing expectations and practices. But I'm not sure it's a one-to-one. I mean, we're kind of in a phase where we're trying a whole lot of different things, and I'm not sure that value-based payment systems lead in a direct line to universal care. But I think they're really valuable mechanisms to explore for sure, and HCA has done a great job of that.
I think, have we reached our time?
Yeah, I think so.
Yeah.
AnnaLisa, thank you so much for answering my rather long and complicated question. I really appreciate
Did a
it.
great job. I could answer your questions all night long, ma'am.
Thanks, Cello, for bringing those forward, and thanks everyone for bringing those questions in. Some of our questions are actually based on what's going on a Universal Healthcare Commission and legislative efforts to improve healthcare, to improve access, and to move towards universal healthcare. And I think one of the things we should recognize is that this board is really supporting and providing data to Universal Healthcare Commission, to other state agencies. So this is important work, not just directly of what we're seeing and can see in your meetings, and to what you're doing with other boards that are moving the effort toward universal care. So thanks for doing this. Thanks for showing up tonight. Thank you very much.
Thank you for having me, and good work, all of you, and keep it up. It's important to have an organized consumer voice. We really appreciate it. Good night, everyone.
And I'd like to thank volunteers, Rich Legoo and D.W. Clark, who are behind the scenes. Thanks for helping make this happen. Thanks, Cello, for bringing those questions in. Peter, for talking the strong words about putting money into this effort. It's sometimes hard for us to push that forward. And most importantly, thank you for people who submitted questions and people for joining us. It makes a difference to people that are making presentations like this to know that we're out there listening. So thank you, thank you, thank you, and have a wonderful evening. Good night.